Today, in this talk, we're probably going to go a little bit different than some of the talks before. There'll be a few more feels and a few less facts, but it's also about, for us, a bit of vision casting of what's it going to look like when we get the convergence of interoperability, the work that the Sparked program's doing, and the work that capabilities that are in the InterSystems platform to bring the most important clinical data to the doorstep in the hospital, in the home context. I'll be sharing some personal details about my personal family stuff today. It's part of the story. We all are motivated by different things, and for me, there's a very personal connection to all of this, and I'll enjoy telling you about that. But I think the journey for us is to basically get to this point where we recognise software has been built really well for the hospital settings and for the four walls of the hospital. But we face the challenge now that as services move to people's homes, how do we keep that continuity of care? And I'll work through some examples and things. Today will not be about AI, but there is one AI reference and one dad joke, and they are combined at the end of this talk. And there's also a little Easter egg on the last slide, so I'll get you to whip your phones out at that time and have a look at the QR code. So a little bit about DidYouGo, just to let you know what we do. We've launched this year in 2025 and basically brought to the sector, particularly the aged care and disability sectors, a solution to, and I might just quick survey the room, people who have an aged care accountability in their world. Quick hand up. Thank you for what you do. You've got 32 hours until reforms start. And we're here for you basically. So this has been built in response to a particular problem that came out of the Aged Care Royal Commission, which was in aged care, we don't have the proof that external third-party workers actually ever attended a job. We have invoices, but we don't have any evidence. And so things have changed, the policies have changed, and it says we now need evidence from Saturday. And so DidYouGo is the ability to basically get that at the doorstep, quick check-in and check-out experience. So that's where we start our journey, is with the basic compliance requirements. But where we end that journey and where we want to go is DidYouGo for Health, which is ultimately why we're partnering with InterSystems. It's about having a version of DidYouGo that is clinical grade and able to move things like patient summaries to the doorstep with that real confidence. I'll start with a bit of context in Victoria. So we have the Better at Home program in Victoria. I'm not a clinician and not an expert on where things are at in the state budget, but $800 million over the last couple of years, few years has been put into that. And we have 49 hospital in the home sites operated by a number of organisations in this room. And really, we have this tyranny of distance problem in Australia, but I'm reminded that I'm not supposed to say that too much when I'm in Victoria and I'm dealing with people from the Northern Territory. I did write down 6 times the environment. I also wanted to call out a couple other things from people have talked about today. So Dr. Ramos spoke this morning about AI and safety, and there was a phrase that really hooked into me, which was tiny margins, human cost. And my personal experience, my family's experience has been, there have been moments of tiny margins of things that could have gone right but went wrong and resulted in some pretty bad outcomes. But there's some positives in there too. Also, as we've seen today, some of the demonstrations are about what's possible in the future. So today is going to showcase some of that, what's going to be possible. Plenty of talk today about too many clicks. I've loved hearing the too many clicks phrase today because it's something I live with every day and hear from end users and people all over the place now. I was saying before that it used to be our systems don't talk to each other. That's what IT people were told as the biggest gripe that the business had with systems, and now it's too many clicks. So our challenge is to make every click count, and DidYouGo is part of that to do it really efficiently. So in Victoria, famous for distance, I won't do the thing other than to say Mildura to Melbourne, Warrnambool to Wangaratta. You're welcome to come up with any others. And about a quarter of all Australians live outside of metro areas and have to deal with long distance travel and other things, but we need to get care to those people in their homes through hospital in the home programs. And it becomes a tyranny of access problem. The distance becomes irrelevant actually about, can I get the data where I need the data to be? So it creates a great opportunity and a big shift in how care is delivered. And I think fundamentally most people in the room will have experienced that for the right settings and for the right requirements for a patient, hospital in the home results in people getting better faster. They're recovering in their own environment. They're with their pets, they're with their family members. It ticks all the boxes and it has all the benefits on the system as well. So about 350,000 admitted bed days were delivered in Victoria last year through hospital in the home. I think there's 358 beds. And the government talks about that being the same as running a hospital like Footscray, and basically from its size and scope. I'll read a quote from the state government that when they announced their Better at Home program, so this is when they're expanding it. Expanding Better at Home will mean many patients, particularly in regional Victoria, will have better outcomes because they can recover and do their rehab in the comfort of their own home. So it's not theory, it's happening, it's a real service being offered. But what we've noticed in our research and in talking to different health providers is that, and we've seen this in aged care where we do a lot of work. In aged care, about 50% of the entire workforce who deliver care don't work for the company, the primary aged care provider. They're associated providers, they're gardeners, allied health professionals and everything in between. And so we have this hybrid workforce, and the hybrid workforce doesn't enjoy the luxury of having the official device from the organisation issued, the laptop that has the VPN and all those things. And our experience as a family and others has been there are clinicians who turn up well armed with the information they need, and there are clinicians who turn up and just don't have access to the information they always need. So we want to solve for that problem. Better at Home is our Victorian effort towards this. As I mentioned, those figures before, but realistically, home services are now being delivered across NDIS, aged care in the community, transitional care, hospital in the home. So lots of different services making their way across the care economy. Where else? So we talked about the sort of running costs of being equivalent of a Footscray hospital. Also, you notice any AI images that have been generated for this have got a little watermark on them. I'd like to start a new practice for everyone of doing that. But the catch is, obviously, we have sent people home, but the data hasn't always followed them. So how do we close that gap? What we want to talk about is something really exciting that's being developed by the Sparked group and the collective of people working on it, which is our AU patient summary. And right now, if you go and look at the Confluence site, there's 3 great case studies that are being, or 3 great use cases that are being described around things like visiting a GP interstate and how that patient summary becomes a super important artefact to move. We're keen to see it also liberated and made available basically on a phone at the point of delivery of care without the complexity of needing the full laptop, the full VPN and all the paper. Ultimately, the goal is to get people out of hospital faster, to stop readmissions and to basically create capacity in the system that we're struggling with. What we've seen is that people turn up at someone's home with that clinical responsibility and that risk around them, but often they're carrying handwritten notes, referrals or discharge reports. What else is out there? We've got photos that we see on people's phones, and I'll talk about that with my family. And WhatsApp messages, whatever necessity has been being the mother invention, people have found a way to deliver care with the tools they've got, but it's not optimal yet. So we have spent decades working out how to bring data together in one place, and you guys have talked about some amazing projects that are doing that, but we've got to get to this point of liberating the data as well. So we sort of talk about the idea that, if every observation in a hospital is time-stamped, we almost end up in this witness protection mode with data when the patient leaves the hospital. And we want to make that, a totally different paradigm. So we're going to talk a bit about, when we can't bring the people to the information, how do we reverse that? So another AI image, but not a bad one, of a clinician sitting in their car, handful of papers waiting to head into someone's home. This is probably a fairly common scenario, and probably whipping 40 minutes between different places and not knowing if they've got all the right medication information. And from some lived experience, I'll talk about what this feels like as a family and how we work with that situation. But our systems of record, as I said, they haven't become systems of reach yet, and we need to facilitate this. And I think, as I've looked at a number of the roadmap discussions happening, that we've got the 2 to 3 year horizon for supplier portal or provider portals, which are the correct manifestation of getting the data out to everyone. But I think there's some lower hanging fruit potentially that we could say, could we accelerate this part of it for this specific reason rather than trying to build a complete provider portal experience from day one? I'm going to tell you about my sister Melissa, and I'm going to indulge a bit here. This is a bit of a, I won't get emotional, but I'll tell you about my sister. So Melissa was born, well, she was diagnosed with type 1 diabetes at 4. She lost her sight completely at 19, so she had complications from her diabetes that resulted in her, over about 18 months, losing her sight completely. So she's gotten through the world for the last 30 years as a person who's blind. And to go with that, her kidneys started failing 4 years after she lost her sight. So she's had 27 years of waiting for a kidney. But through a miracle of medicine, in February last year, she received a new pancreas and a new kidney, and she's doing great. Excellent clapping. It's not a very common procedure. Some of you might know that an SPK is what it's described as. There's only about 30 done in Victoria and 30 in New South Wales each year. It bypasses the normal kidney transplant waiting list because it's a special procedure, but she was very fortunate. She didn't end up on dialysis. She managed to avoid that, but she was right down at 13% or something function. But the journey hasn't been at all a straight line. I think anyone who's known anyone who's been through a transplant knows that it's just a roller coaster for them. So she's been in and out of hospital 5 times. We've had some pretty major issues that have happened, and probably the one that, again, that Dr. Ramos was talking about was that she had a collection of fluid on top of the pancreas, and that collection had actually started to get infected. She got sepsis. She was at home. She got into hospital in an ambulance, and I got there with her. Went into emergency, dosed her up with vancomycin. She had an anaphylactic reaction to vancomycin. So we had the joy of kind of going through not only all of that pain, but also learning that she was allergic to another drug, not just morphine and penicillin, but more and more. She's so great from a comorbidity perspective because she's just a great case study and everything. But ultimately, Melissa relies on hospital in the home. She needs to be able to check out of hospital and get home and have like 6 weeks of antibiotics, of heavy-duty hospital IV antibiotics. But when you're blind, it's a very, very different experience than if you're sighted. So if someone turns up at your home and they don't know your medication, for example, and they ask you your medication and you're a post-transplant patient and you're blind, you take 15 pills a day and you don't know what they are, and you can't tell them dosages or shapes or sizes or colours. That's the simplest thing that she gets asked. She also gets asked a whole lot of other complicated things, but I think that ultimately is kind of characteristic of, if someone just knew her medication, it would save her a lot of pain and a lot of trying to work this stuff out. And so definitely it is an access to care information. I will say she's had a fantastic experience through Monash and Cabrini and under the hospitals with the Hospital in the Home program. But because there are some different people who turn up on different days, they don't know Melissa, they don't even know she's blind. So she starts from that point at the doorstep with someone. She's a legend. She's the most resilient human being I've ever met, and she's going strong. She's a public speaker. She'd love any public speaking gigs as well. But I think the reason I raise Melissa, and the reason this is kind of personal, is that there is this aspect that says if we don't get this right at someone's home, and we've put that faith in the fact that they're there, they're outside of the ward, they're not observed the whole time, and in this case they're blind, and they do things like stub their toe and end up with needing to get a toe removed, it's not great. So anything we can do as an industry, I think, to get behind all of the convergence of technologies from InterSystems, of standards around FHIR and HL7, this is where we're going to find that patient summary come to life. And keep things, I guess, a little bit in Melissa's context, just as examples to share with you, but I'll reinforce this point that basically our systems appear to be, although we've got some great mobile apps appearing, one of the problems we have with mobile apps and with laptops and all these things, as I mentioned before, is a hybrid workforce. So we effectively have 2 classes of workers. Workers who have first-class access to the systems and workers who don't. And unfortunately, we have to make it work for both. So there's a challenge for us, but I think the challenge becomes not necessarily trying to hook into these systems directly, but also to say, my health record is going to be the place this information lives. Let's build what we can to pull that information from there But because we're an InterSystems partner, an integration solution partner in InterSystems, we'll be building an Iris version of DidYouGo that will integrate with any other Iris platform. We've already built the track care integration for appointment management. So if you raise an appointment in track care, it shoots across and creates a QR code in DidYouGo, links the appointment, clinician turns up and they can see the appointment and check into it. So we don't actually have to overhaul a lot of technology. We don't have to refactor things and redesign things. We definitely don't need another data model. We just need to build some bridges and connect some dots. And really excited, I'm going to be at the Connectathon, the HL7 Connectathon in a couple of weeks, which is going to be fun just to go along to and soak it up. It's a fairly new world for me too. But I'm certainly excited about the opportunity to basically bring these solutions to life as we build towards this national infrastructure coming together around the patient summary. So, appless is important for us in this world. What we've observed as we've gone around doing service confirmation solutions for the aged care sector is you can't have a mobile app. It's going to be a barrier to people accessing a system. There's going to be technical requirements, technical support. It just doesn't work. So we need web-based technology on people's phones, and that's what we do. And I think ultimately Smart on Fire and some of these technologies are going to really unlock the ability to use simple web-based applications that don't need an app to be installed to get the same outcome. I want to call out also that none of this is going to be possible without the fact that all of you and many others have done a whole lot of work over decades to form standards that are going to be brought to life through solutions like this. We need safe, portable data that can be system agnostic, and it wouldn't be possible without standards, without things we can hook into and design for. So we'll work closely with the InterSystems team and people like Juanito and his team to help us get this right from an Iris perspective, but ultimately the standards are there to make us successful. And as I mentioned, we didn't start in the context of healthcare and hospitals. This for us was a play. This for us was a strategy that said we need to fix a problem in aged care and disability services first because they have a fraud issue and a compliance issue. Let's hit that first, and then let's work our way towards clinical solutions. So we're doing the care verification. It's fairly straightforward. If you're in aged care and you need to do a supported home compliance piece around how do I know our third parties have delivered, then give us a call. So behind all this, as you know, lies a whole lot of good technology. We will be standing up our Iris instance and getting all the advice we can about how to make that work best for the interoperability needs we have. People like Raf and Josh that you probably heard from before, we want to get their advice and really soak up the best practices. So we think we'll end up with a really neat solution that has not too many clicks as well at its core. And as I said, this is dealing with a problem of a hybrid workforce. This is not we can't start with the assumption that everybody works for the organisation. So I'll describe basically the experience of what we anticipate for a clinician. And you'll see in the little demo at the end that you can have a play with. The idea is that, as we do with the aged care workers and disability workers, people actually are able to register themselves into the system. We'll probably do things a little differently for the clinical context, but we don't want to add an administrative layer of having to administer third-party companies and all of their workers on top of the workload you already have, when this solution actually can work with a self-registration process and people owning their own identities. So that's a big core part of our design, is to not add a layer of complexity for organisations to manage this. And basically our other view is that any data we get that's clinical has to be destroyed. We don't want to keep clinical data at any level at all. So you'll also see in the little demo a bit of a self-destruct mode that says this is good on your phone until it's not good on your phone, and we'll make sure this data doesn't hang around in places it shouldn't. Also, just quickly mention that globally, this is hospital in the home has taken off massively. So the UK has 12,000 virtual beds now, or 12,000 beds in a virtual ward. It's part of their national health infrastructure. I'm not sure what the numbers are nationwide for Australia, but certainly got the 350 in Victoria. This is growing. This is going to be something that we see more and more of. It's a successful model, and it's needed in a place like Australia as well, where we've got limited, longer waiting lists and things we need to solve around bed blockages. Hospital in the home becomes a great way of diffusing a situation if we have that alternative. So Hopefully, we end up with shorter hospital stays for people, more elective surgery getting done, shorter waiting lists, all of those as the virtuous outcomes that come from getting people back home, as well as their own recovery. I think, where we want to land is that we wouldn't end up in a situation where a clinician would turn up to someone's home and ask the question, what medication are you on, to a blind person who's just had a transplant. We can get there. I think we've seen some of the patient summary data coming today from in the systems and how quickly that patient summary can be compiled and how accurate it can be. And I certainly think that's the framework we're going to be using, but we want to chase the My Health record. We want to see, even though the adoption's not there yet nationally, we're sort of going to bank on the fact this is national infrastructure like the NBN. We hope that adoption will rise quickly. And certainly once the patient summary is out there, hopefully lots of people advocating to say, there's a great reason for you to be on this. Just talk quickly about the settings for us that we're working in. So we benefit hugely from the digital health roadmap that brings everything together and says, we've got a common objective. All the work going on the My Health record is hugely advantageous to this. So we've basically got 4 things that are harmoniously working together to one outcome. And looking forward over the next 12 months to taking more and more involvement in those programs like Sparked and other things. So for us, we want to build sort of working prototypes first and get that test case out there, start showing people what's possible, and then work out what the policy settings are that need to be in place to make this happen, and start the lobbying and start the whatever it takes to get people to update privacy standards and things like that. It's a collective effort. So I think with where we're heading as a country, we seem to have the settings right for enabling these sort of outcomes. Probably also just call out, from a DidYouGo perspective, I had one of Katarina from Moyne Health was talking to me before, and she said, it's a really simple solution. And I was like, yeah, that's the biggest compliment you can give to a technologist, is that something simple. And we're just going to persist with that. It's sort of non-negotiable for us that we need people to deliver care, not to spend time fiddling around with devices. We give ourselves a 15-second to 30-second maximum check-in time that says if you're taking longer than that, we're stopping you from doing your work. So that part of us keeping things simple means we're just really joining the dots and building bridges between systems. We don't have a huge technology stack. And one of the things that I think has been mentioned a few times today, and it's, even when you're talking about massive transformation programs, it's challenging. I think Ken was talking about, it's a change management piece more than a technology project. This stuff genuinely is change management, not a technology project, because the technology is actually quite simple to put together. I think as we sort of head towards the next couple of years, we need a trajectory that says when is this going to be possible, and start to understand when the patient summary will be viable and realised in My Health record, but certainly we think it's close enough to start working on these types of solutions. And being an integration partner with InterSystems opens up a whole lot of opportunities for us to work with you guys and to work with the team at InterSystems. You've talked so glowingly about collaboration with the team at InterSystems, and we've shared a similar experience as integration partners, that they've stepped up and helped us, they've solved problems for us, and they made it really easy for us to basically build around the system. So thanks, Darren, for your support for our team. It's been great. I have an engineering team over in Nepal, and by a happy accident, one of Juanito's guys, Piyush, who I think helps out in the Northern Territory team, is a Nepalese person as well. So my team and Piyush get to talk to each other in Nepalese, and it's kind of a really awesome little coincidence of the settings, but it's made it really productive for them as well and enjoyable. So we're tracking as a national metric the readmissions after 28 days or before 28 days per thousand separations as a quality indicator, and we're going to attack that. That's our measure of success, is have we made a contribution towards reducing those readmissions, because we've actually enabled clinicians at the doorstep to have that key information. And what does it look like? It's ultimately what you'd expect a patient summary to be. It's medication, it's conditions, it's allergies. It's the things that matter most in that moment, not the full medical picture necessarily. As I said, Melissa's had 5 readmissions since February last year. 4 of them were unplanned and 1 of them was planned. In fact, she's had 6. We were there on Tuesday having another angioplasty and some other stuff done. So 2 planned and 4 unplanned. We don't want any more unplanned hospital visits for Melissa. They're a disaster when they happen. If she's heading into hospital, it's usually a pretty dangerous situation. So not just about saving money, not just about trying to get people out of hospital beds as quickly as possible, but genuinely, families like mine, and I'm sure a number of your families have benefited from these services. And when someone's really, really vulnerable, we need to do the absolute most we can do to make their life as easy as possible. And we're just stopping one step short of that, I think, at the moment, which is we're not quite getting the information people need in their hands when they turn up at someone's home. So that's the challenge to all of us, to all of you, and we're looking to partner with organisations who want to do the research and actually prototype things like this and see how it would work, test out what are the settings lobbying-wise and legislative-wise that need to be tested to say there's consent here, there's security here, what does it take to make this data available where it's needed. And I'm going to leave you pretty much with just an image. This is Melissa's house. That's her front room. And she's in there right now, recovering from surgery on Tuesday. But she is doing great. She's absolutely a child of this incredible health system that we have in this country. She's alive because of the people in this room. And she's probably got another good 15 years ahead of her, but she didn't have that 18 months ago. So genuinely, I'm going to take the opportunity today because I don't get in front of a lot of clinical people. Thank you genuinely. You do things that you can't imagine how big a difference it makes to people's lives. So thank you very much for your time today. It was a bit of a, what does it look like when we get this right? There's a little demo that is on this QR code. Oh, I promised you a joke, a really bad dad joke. And AI. So I asked ChatGPT to come up with a funny picture of someone saying "hith," and the best we could come up with was Mike Tyson's famous lisp. That's our contribution to AI. We do a lot of AI stuff in DidYouGo around bad actor detection. We need to be really careful there's not people gaming the system. So behind the scenes, we're doing a lot of heuristics and other things to make sure people are safe and that bad people aren't trying to do things with the system that they shouldn't be. But this was the best AI could help me with today. And at that level, I'll say thank you for your time today, and I'll ask you to scan that. It is not a lead capture process. It is not a video. It is interactive, but it might be a bit weird. But you'll see some blue buttons pop up for signing up or signing in and submitting a SMS message. And it'll just give you a feel of what the flow should feel like for a clinician turning up at a doorstep or inside scanning the QR code on a fridge and walking through a process of saying, right, I need to grab your patient summary and you've consented to it and let's get hold of it so I've got this information in front of me and then let's get rid of it because I shouldn't keep it.